Hello everyone, welcome to this session of PYQ discussion, that is NEET PG previous year questions. And I assure you that whatever discussion I am doing for you today, at least in the coming NEET exam you'll be getting good amount of questions from this discussion also. Well, before I start my session, I request all of you not to switch off the mobile. Well, but I want you to keep them in the flight mode, because during the discussion I'll be asking you a lot of questions and I want you to reply to those questions. That is only possible when it is in the flight mode, otherwise switching off on the phone again takes a lot of time. And it will be interactive session, and I want to each one of you to take active part. Answer of your may be wrong or right, it's immaterial to me. If your answer is right, correct. If it is wrong, it is better, because whatever mistake you will do here, you will not do in the exam. So I hope by now you have done the needful of putting your phone into the flight mode. So let's discuss question number 1. Well, in this question, we have the keywords I have highlighted so that you know what are the points you have to focus, because at the moment I know you are not carrying your question paper with you, but at least you should know where to focus. Of course, in the class we do give the paper in advance. However, we are getting a 68-year-old patient. His systolic BP is 190 and diastolic 100. That means his BP is 190 by 100 if I have to write in this way. Well, his heart rate is 74, is normal. Definitely the pulse pressure is wide. How much? 190 minus 100. The pulse pressure in this case is 90. We also know very well the normal pulse pressure is about 30 to 60 millimeter mercury. Here it is definitely more than. The question is why, which it is occurring due to what reason? The other 4 answer in front of you. All of you mark the answer, write down the answer in your copy A, B, C, D. I give you 20 seconds to think and answer. Every question will be like this only. Before I discuss, you should write down answer in your ABC. But whatever answer you have to send me, I'll inform you well in advance. Well, I hope you have written the answer. The answer is arterial compliance. Here I like to note the classical keyword here is 68-year-old patient and systolic BP high. There are 2 keywords to be remembered, to be noticed in this particular slide, because the whole answer is based on these 2 particular words only. So, well, the patient age is 68 years, as I told you. With aging, there is decrease in compliance. The keyword is compliance of large elastic arteries. Reduced compliance means they are not able to expand properly during systole. But why it is there? There is a decreased elastin content. As the age increases, elasticity goes away of the artery, and there is increased collagen deposit. But out of this, most important is arterial calcification, which increases stiffness. But if I ask you what is the site of this calcification, most of you will go for tunica intima. That's the most common wrong answer. Answer is tunica media. And the pathology what we occur is known as arteriosclerosis. It is arterio. It is not athero. Athero occurs in tunica intima. So artery becomes calcified. Now, again, a clinical integration of this line. If you read Hutchison, rather everybody has read Hutchison. And the first thing that we read in Hutchison is when examination of system is pulse. Pulse, there are so many things, rate, rhythm, etc., etc. The last word of the pulse written in Hutchison, character of the arterial wall. And we read a word called cord-like artery, and the cord-like artery is due to this phenomena. So cord-like artery and increased systolic pressure occurring in an elderly person is due to this so-called, and this phenomenon is also known as isolated systolic hypertension, also known as pseudo hypertension, because in this only systolic BP is high. What is the other effect? This is what we talk about artery. What about left ventricle? Now the left ventricle has to contact again this stiff and less compliant artery, and this is the reason systolic BP rises. But what else happens in the myocardium? There occurs a left ventricle hypertrophy. So in due course of time, there will be left ventricle hypertrophy also. So friends, the key word in this particular slide are decreased compliance, elastin increase, collagen increase, elastin decreases, collagen increases, and arterial calcification, so-called arteriosclerosis. So they are these 5 keywords in this particular slide. And in this slide, there is left ventricular hypertrophy, systolic hypertension, also known as pseudo hypertension. Now let's come to question number 2. We are getting a patient with prosthetic cardiac valve, and we want to give amoxicillin regime for, of course, endocarditis prophylaxis. Okay, so which one you will give? The key word is prosthetic cardiac valve and amoxicillin is the regime. So there are different regimes are given. What is your answer? You get 20 seconds to write down answer. Just write down A, B, C, D in your copy, then you check it. You get 20 seconds to think an answer. Which pre-medication will you give in this particular case? Well, I'm sure, and it is one of the most frequently asked questions in the NEET PG. Answer is 2 grams 1 hour before the surgery is the answer. Well, so we have to give prophylaxis to prevent endocarditis. Now, there are many regimes are there which I'm going to discuss in the next slide. But one thing common is all are given single dose 60 minutes before the procedure. This is the key word in this particular slide. It is 60 minutes. Surprisingly, this is also a very frequently asked question. The question can be changed this way also. You want to give amoxicillin, how, when will you give? You will give just before surgery, just because 30 minutes before surgery, 60 minutes before surgery, or something, various option will be there. The right answer is 60 minutes. The only keyword in this particular slide is 60 minutes. And second thing is single dose. We don't repeat a dose as of only for prophylaxis. Now, this is very simple, but I believe I tell you 90% students get confused in this particular slide. So let me simplify. The duty of a teacher is to simplify the matter. So, situation number 1. This is situation number 1. Patient is able to take oral medication, okay, and patient is not able to take oral medication. This is 1 and this is 2. This is Roman 1. Well, of course, this is all related to amoxicillin. You can write down amoxicillin. Routine patient. Patient can give amoxicillin. The question is there. Is the most widely used, and of course 2 grams oral, definitely oral. But patient cannot take oral medication. What to do? In that case, again, amoxi 2 grams IM or IV. No need to say all are 1 hour before. That point has already been told to you. Whether IM, whether IV, oral, or to be given 1 hour before procedure. Now, scenario number 2. Patient is allergic to penicillin or ampicillin. So definitely patient come to you, patient goes to a dentist and he says, I'm allergic to penicillin or amoxicillin. Then what to give? In those cases, we can give clindamycin. Just to inform you, although amoxi is the one, but other drugs that can be given, which I forgot really, so they can also be given, these drugs can also be given in place of amoxicillin. Okay. Now, patients are allergic to penicillin. In that case, you can give clindamycin 600 milligram before the procedure, or we can give azithro or claithro, again 500 milligram single dose before the procedure. But now patient is allergic to this scenario number 1, scenario number 3, scenario number 4. Patient is allergic to penicillin or ampicillin and unable to take oral medication. Then cefazolin or ceftriaxone, clindamycin we can give. So they are the drugs. Normally they do not ask the dose, but somehow it is the only question where dose is also asked. Otherwise you must have noticed in every exam, as per protocol, doses are usually not asked, they simply ask the name of the drug. But this is an exception. So I hope you are clear about it. The fourth scenario, oral, first scenario and second Roman scenario, and again we have 1 or 2 oral or IV. Question number 3. We are getting one patient with RH incompatibility, which will not be seen. Now, RH incompatibility, there is patient of blood group A and by mistake he has been given B. So that lead to RH incompatibility. Definitely no need to say it is the one condition which lead to, of course, there are many things happen, but as far as this question is concerned, the patient has developed acute hemolytic anemia and it's a type of so-called intravascular hemolytic anemia. Okay, so what will happen? Out of the 4 options, again, I give you 20 seconds to think, mark the answer in your copy A, B, C, D. I hope by now you have done it. Okay. The answer is increased bilirubin in urine. So what are the keys? Now let's discuss the case, and the keywords are, as I discussed, this happened in a cause hemolytic jaundice. The word hemolytic jaundice means the jaundice is due to hemolytic anemia, the point I mentioned in the previous slide. Now what happened? Unconjugated bilirubin will be produced. I'll be discussing the biochemistry in the next slide. As of now, just write it down. This bind to albumin. Okay, so there are only 2 keywords. These 2 keywords, hemolytic anemia and this bind to albumin. Don't write third point that I'll discuss in the next slide. So I hope by now you have written these 2 lines. Now let's learn the basic biochemistry of bilirubin production. How bilirubin is usually produced in the body in the normal situation. We all know that is the RBCs break down and they produce hemoglobin. Everybody knows. In fact, 70 to 80% of the bilirubin is being produced by hemoglobin only. It produces heme. Now, beautiful question for you. Write down the answer in your copy. Write down the answer in your copy. I have mentioned that this heme is coming from hemoglobin. Write down the answer in your copy. What are the other sources of heme in the body? I give you 30 seconds to think and answer. The question is other sources of. What are the other sources of heme? This is a rank 1 question. Question for basic biochemistry not known to 90%. Okay. Rather, I can say one thing more. What you can do, you can very well send this answer to my personal WhatsApp number. Personal WhatsApp number, you send it right now, my mobile is off, but you can send. The question is answer, send me. Okay, what are the other sources of heme? Okay, well, the answer is myoglobin, and cytochrome. Make a box of this line also. So now you got additional knowledge that 30% of the heme come from these, and 70 to 80 come from hemoglobin. Now this get converted into biliverdin, and biliverdin is bilirubin. This bilirubin is unconjugated bilirubin. I am writing UB. UB is unconjugated bilirubin because conjugation will occur in the liver. As of now, it's not. As I mentioned in the previous slide, this unconjugated immediately get attached to albumin. So this bilirubin we also call as indirect, is unconjugated, also known as unconjugated, and we also call as prehepatic. Why prehepatic? Because the rest of the process conjugation will start occurring in the liver. So there are three keywords that you got to remember in this particular slide. So indirect, unconjugated, and prehepatic. Okay, so now let's learn more about the basic, and let's integrate this knowledge of biochemistry to internal medicine or pediatric. Now most of you are not aware the unconjugated bilirubin which is produced is a highly toxic molecule. What do you mean? This molecule, this one, which is yet to get attached to albumin, is a highly toxic molecule, and it is a diffusible also. Note it down is very carefully. It's a diffusible, it can diffuse to any part of the body, where in particular I am going to discuss in a minute only. So now as I told you, it get attached to albumin and now it becomes non-diffusible, non-toxic. God is the greatest engineer. He has designed our body in a very beautiful way. A toxic material is getting produced, but it immediately get neutralized also, counter by getting attached to albumin, so it becomes non-diffusible. Done. So more clinical integration. That's why unconjugated bilirubin is not present in the urine, because it is attached to albumin. Albumin is a very big molecule. So in any condition where we have a prehepatic cause of hemolysis, the jaundice, that is hemolytic anemia, bilirubin will not be there in the urine. Now let's integrate with newborn pediatric, premature child. Binding to albumin is not proper, and moreover in a premature child the blood-brain barrier is not fully developed. So now this unconjugated bilirubin diffuses into the brain. Remember what I mentioned earlier, your basics are strong. The unconjugated bilirubin which is not attached to albumin is diffusible. That is the basic pathophysiology of so-called kernicterus. Okay, you must have read in your pediatric that kernicterus occur in the newborn child, especially the premature. This is the basic physiology. Now one more clinical integration. We learned that hemolytic anemia and more extra heme getting produced, and this will lead to increased unconjugated bilirubin, the point I discussed earlier. So that is so-called prehepatic jaundice. This point has already been discussed in the previous slide, but again to highlight. So let me give a full screen to you. All the yellow colored points are important points, and you might get one question from this particular table or slide, okay, because this is a universally asked point. So friends, I am leaking the paper to you, but in a very honest way. Okay, study should be fun. So I hope you have written it, done it. So we move further. Most important finding in CKD is a beautiful question. The 4 options are there. Write down the answer in your copy, A, B, C, D. Well, I am sure by now you have done it. Well, it's a bit overlapping question, but out of all the 4, this is the most important answer. Can it be there? Let's see. Reduced GFR more than 3 months is the best option out of that. There is a tough competition by proteinuria also, but at the moment it is second. Why? I'm going to discuss in a minute only. So CKD or chronic kidney disease, or nowadays they call it end stage renal disease, all meaning the same. We have a so-called KDIGO classification. What is this? KDIGO stands for Kidney Disease Improving Global Outcomes. KDIGO is the short form. Now it defines CKD as follows: abnormality of kidney structure or function. Point to be noted, abnormality may be in the structure, anatomy or physiology. Either can be there. It's not one. This is a basic pathophysiology. Present for more than 3 months. This 3 months is a key word. It has to be there for 3 months. This question can be asked to you this way also. There is one patient who comes with acute renal failure, what nowadays we write as acute kidney injury. Okay, but deliberately I am writing ARF, and he is going into CRF, chronic renal failure. Patient has got acute renal shutdown now, not able to pass urine, urea creatinine is going high and high. You try your level best, today started, but now time has come up to 3 months, patient could not improve. Now suppose the time has gone to 4 months. Same patient before 3 months was ARF, acute renal failure. Same patient where the renal kidney function has not improved even after 3 months, we call it the word CRF. So again, a simplification subject. These are two countries, country A, country B. The name of country A is acute renal failure. Name of country is CRF. Second country, and the boundary line is 3 months. If this goes to that, 3 months later, the same thing is called as chronic renal failure. I hope you understood the single meaning. Only single keyword here is 3 months. Well, let's see more. Now, 3 months is one thing, 3 or more than 3 months. But there are two criteria are needed. Number one, GFR reduce. In actual is less than 60 ml per minute per 1.73 m2. But for again, for easy understanding, I'm just writing 60, less than 60 ml. Is it enough? No. Albuminuria is the second criteria. Most of students are not aware of this point. Not aware of this point. The patient having only albuminuria for more than 3 months, okay, is again a criteria of labeling a patient of CRF. So now 90% students are not aware that patient having only albuminuria, GFR may or may not be reduced. Underline my words, may or may not be reduced. It can also be called as CRF. What is this? I'm going to discuss in a minute. However, reduced GFR is the most consistent feature of CKD. What it means to say is a very important finding by which a patient is usually caught. But one more thing, GFR is the one investigation, not a very routine investigation. What do you mean by routine investigation? Patient of renal disease come to you, you'll have to go for urea, creatinine, urine routine microscopy, blah, blah. But normally GFR is not a routine test done by in the routine practice. So again we go back. So we come to this slide again. So this was the reason why I told you why this is the answer, that is clear to us. Now let us look into other options before I really, regarding proteinuria. Again, I told you it is the albuminuria. Okay, albumin is also type of proteinuria. Sir, why can't we take this? Yes, good question. But remember, first of all, he said that the problem for be of more than 3 months. There is nothing mentioned about time. Patient may be perfectly all right, and maybe his urine test was done 1 month back. Today, yesterday he come and urine albumin positive or protein positive. Can we label him as a case of CRF? No way. So that's why this is not the answer, but point to be noted. Now let me change the question. Let me change the question to this one. Okay, here now the question goes like this. Reduce GFR, that's all. And now this is could be I write albuminuria, albuminuria more than 3 months. In that scenario, this is the right answer. Here he said reduce GFR. Reduced GFR occurs in acute renal failure also. But proteinuria more than 3 months is a better answer. What about this? This happen in both ARF, CRF. This again can occur in both ARF, CRF. So it is out that I told you. The only computation is proteinuria. This is the rank 1 question. 99% students are not aware that this, out of this question now it become rank 1 question. The previous question was the actual question, but was a routine question, but now it become rank 1 question. So we understood all the 4 options. So let's see. So we learned GFR and albuminuria. Now I show you this picture is given in all the books, so no need to write, just try to understand. So as I mentioned, KDIGO classification give you this all KDIGO. Okay, one is reduced GFR. This whole is reduced GFR. Criteria are given. I got limited time to speak, so I can just at least give you idea what the slide is. Because this, if I discuss, it will take a lot of time. Time is constrained. Second is about albuminuria. Second criteria is albuminuria. Well, in albuminuria, I'll focus on this particular slide. We classify A1, A2, A3. So when it is more than normal or mildly increased, less than 30, 30 to 300 is A2, and more than 300 is A3. Point to be noted that they have classified A1, A2, A3 simply based on the albuminuria. And one more thing, beautiful color combination they are given, green, yellow, then this orange, then red. As it goes, color changes. You can see the even severity of the CRF is also increases. Similarly, okay, so point to be noted that if this is the category, this is again for GFR also, GFR on this side, albumin on this side, you can see the color change occurs. I think it's a brief introduction to this table. Many of you may have listening for the first time. At least you understood one point very clearly, that chronic renal failure is based on 2 things, GFR and proteinuria, or better albuminuria. Question number 5. The T-score is used in diagnosis of osteoporosis. Is a well-known disease, okay, more in ladies after the menopause, well-known fact, and that's why these patients are more prone to which fractures? Colossus fracture, neck of femur, and vertebra. Because in osteoporosis, the bone is weak. Right, sir. Now, and one more thing, 99% students are not clear about the basic pathophysiology of osteoporosis, okay, and why this osteoporosis happen, why biochemistry is normal in these patients, what is the actual thing at the cellular level. Point to be noted, what happened at the level of cell in the bones. Of course, we know there are so many cells in the bone, and there is matrix also, there is proteins also, and organic matter also. This is not clear too. So I'll be giving you my number later on. You can send me so that I can send what happened in the osteoporosis. It's This is a rank 1 question. But as of now, let me talk about this question. He says, what's the T-score in the healthy person? Well, so T-score is, normal is more than, I think it's a better slide, T-score. Point to note it, the T-score is from -1 to +1 is normal. -1 to -2.5, this is osteopenia. And below -2.5 is osteoporosis. So friends, in normal person, it is -1 to +1 T-score that we check by DEXA scan. Best fit for factor 8 replacement is, again you get 20 seconds to think and answer. Best replacement fluid is what? It's a bit simple question. Just write down A, B, C, D. Written. Cryoprecipitate is the best out of all these 4. So how we really manage a case of hemophilia in general? Well, patient has come with bleeding. No need to say that blood transfusion will be given depending on how much blood is lost. It's just a symptomatic treatment. Now we can give factor 8 concentrate. This is from donor plasma. This is one way of treating. This is not a very first line treatment, but it is done in those centers, in a small center where there is no factor 8 available. Then we use this, but at the back of the mind you should know that plasma has, in fact plasma has all types of clotting factor except calcium. Now second line treatment is this injection desmopressin. This can be given to raise the factor 8 level to 3 to 5 times. That's what we wanted. But the question is, how does this act? What is the mechanism of this? Is the rank 1 question. How it increases? All of you, again I told you your phone is in the flight mode. You can send the answer right now. Type the answer and send me in this particular number. I give 60 seconds to think. This is the rank 1 question. What is the mechanism of factor 8 for the mechanism of desmopressin in treating hemophilia? You get 60 seconds to think and answer. WhatsApp me immediately. Right or wrong is immaterial. Definitely those who will be sending the answer to me, you'll be getting reply also quickly. What the mechanism of action of desmopressin in the treatment of and hemophilia? I'll be acute bleeding in particular. WhatsApp me, or those of you who do not want to WhatsApp me, at least you write down the answer in your copy to check the answer. I think by now you must have done it. Why? It is effectively by releasing subendothelial store of factor 8. Point to note, this is subendothelial source is not only liver, other body part also. Of course, maximum from liver. This is the basic mechanism. How desmopressin increases factor 8 level by release from the store. Cryoprecipitate is the best source of factor 8. That's why it's the most widely used. It's the answer also. Okay. It is actually giving you factor 8. And finally, we can give also certain drugs which are anti-fibrinolytic drugs. That means they prevent the breakdown of fibrin clot. That include E-amino caproic acid or tranexamic acid. This is much more widely used in actual practice. So I hope, friends, that you got beautiful question in this particular slide. Point number 1, point number 2, and point number 3. There are 3 keywords to be remembered in this particular slide. question number 4. This next question, sorry, next question, 7 number. A chronic smoker who is a known case of COPD, so it has justified why he is a smoker, COPD. Present with acute dyspnea, ascites, bilateral pededema, and raised JVP. Which chamber of the heart is most likely affected? If you look into this, this is in fact is a part of COPD itself also. But as far as ascites, bilateral edema, they are usually not directly associated with the case of COPD. This happens when some additional pathology is there. Now the thing is, what is the additional problem? And that is due to which chamber of the heart. One thing is made very clear, there is some cardiac involvement is there. So there are 4 options. Write down the answer A, B, C, D right now in your copy. You get 20 seconds to think an answer. 20 seconds, think an answer. Okay. Yeah, I hope by now you have done it. Answer is right ventricle. This is a case of cor pulmonale. The other name of the disease is pulmonary heart disease. It's not a very commonly used term. That's why most of students are not aware that there is something called pulmonary heart disease. What is this? So cor pulmonale is the right heart enlargement. With or without failure. Secondary to lung parenchyma, pleura or chest wall disease. The most common wrong answer is right heart failure. No, it's not necessary. Even hypertrophy is not the, it's enlargement. So the keyword is one keyword, second keyword and third keyword. Since it is secondary to some lung problem, the lung problem can be in the parenchyma, pleura or chest wall, anywhere. Chest wall disease also is again can contribute to cor pulmonale, and the most it's the most common cause of tricuspid regurgitation, the 4 keyword. We are all well aware that all the valvular heart disease, MS, MR, AS, AR and TS, they're all common in rheumatic heart disease. This is an exception. Only exception is tricuspid regurgitation, which is common in most common in cor pulmonale. Now again a question for you. Send the answer, WhatsApp me immediately. In this patient of TR, raised JVP I mentioned here also in the question also, because raised JVP is there. Now my question is, in this patient where tricuspid regurgitation is there, which finding you will get in JVP? Well, again I'm writing my number, those of who joined late, send WhatsApp me. WhatsApp me. What the JVP finding in this case? Question in your screen, which is the case of cor pulmonale by which we have discussed. Just write down what will be JVP finding. All of you WhatsApp. Wrong, right is immaterial to me. That's why I asked you to keep your phone in the flight mode. Yeah. The right answer is V wave. Prominent V wave is the right answer. I'm sure each one of you must have done right. Question 8. A 40-year female, she has dry mouth, dry eyes, positive for anti-RO, anti-LA antibodies. Which drug can be given? It's a bit simple. Question is simple, but answer is a bit tricky. What the answer? Write down the answer in your copy, A, B, C, D. Well, the right answer is cevimeline. It's a case of Sjögren syndrome. Okay, why? what the disease is an autoimmune disease. And that leads to destruction of the salivary gland, lacrimal gland. Salivary gland will lead to dryness of the mouth, and the lacrimal gland are the eyes. Classically, these patients feel their mouth is totally dry and eyes are always gritty. If you talk to this patient, you say, what the problem? He will say, doctor, it looks some particle, some dust particle has entered my eyes, and he will keep on rubbing all the time. It's a classical history that we get in case of Sjögren syndrome. Okay, mouth is dry, totally dry, much more in females. In the middle age, 40 to 60 female is more common. In fact, this can be primary in isolation, that is idiopathic to be more precise. Some people write IDO also, idiopathic, some books write idiopathic. Anyway, secondary, the commonest cause is RA. RA is the most common cause of secondary rheumatoid arthritis. It can occur in SLE also, Hashimoto, all are autoimmune disease. One more thing you got to understand, in one autoimmune disease, other autoimmune disease can be there because they all belong to same family. There is one patient of Hashimoto that can develop Sjögren syndrome like this. They all belong to same family. Now, the clinical feature, dry eyes, burning, itching, foreign body sensation, what I mentioned, is very common. This foreign body sensation is very common. Dry mouth, difficulty in swallowing, loss of taste, enlarged parotid gland. So, third feature, that which is a part of Sjögren syndrome is bilateral enlarged parotid gland. Okay. Well, there is no saliva. To compensate that saliva, the parotid gland will try to enlarge so that they are able to secrete large amount of saliva, but that is not possible because in due course of time, all glands are destroyed, or secretory part of the gland is destroyed. However, as far as we are concerned, exam point of view, the classical tie is dry eye, dry mouth, and bilateral parotid enlargement. Out of these also, these two are the real essential criteria. Lab finding, they have antibody again, SSA, so-called anti-RO, or SSB, anti-LA antibodies. Just to inform you, these two antibodies are also present in SLE. Treatment of Sjögren syndrome, treat the basic cause, whatever cause, if it is a secondary. Otherwise, dry eyes, artificial tear, ocular cyclosporine, pilocarpine, and cevimeline. These two are the drugs which cause increased secretion of saliva. Okay, but a symptomatic treatment is not going to change the disease process. So that this important keyword, the keyword to remember in this slide are 1, 2, and 3 are the keywords to be remembered in this particular slide. Well, again, yellow color are the highlight mark. A chronic alcoholic, 40-year male, brought to you for visual disturbance. Gait is abnormal. He also has amnesia. He's confused. What the immediate treatment he's talking about? Well, now, before I discuss this question, let me add one more thing. This patient has come to you. His blood sugar at the moment is just 30 milligram %. Okay. So I add here one more thing, IV dextrose. So question number 1 is this. Patient has hypoglycemia also. And these are 5 options. Write down the answer in your copy, no need to WhatsApp. So this is the scenario to treat this thing. What you will do the first out of these 5. I give you 20 seconds to think and answer. Write down the answer in your copy. Well, listen to me, in this also, what the first line treatment you will give? Well, the right answer is dextrose. How many of you have done it? Raise the hand, raise the hand. Dextrose. This is the most common wrong answer. It's the most common wrong answer. Answer is IV thiamine. Well, what is this? Yes. Even sugar, this, first you give thiamine, then you give dextrose in this scenario. If you give dextrose alone, it is definitely going to precipitate more about the problem for which patient has come to us. So IV thiamine is the first thing we gave, because this is what the case which has already come to us is a case of Wernicke-Korsakoff syndrome combined with Wernicke's encephalopathy and alcoholic Korsakoff syndrome. Is again a big topic to discuss. Briefly, I'll touch Wernicke encephalopathy need a triad of ophthalmoplegia, confusion and ataxia. Okay. Well, in fact, what they use is global confusion, ophthalmoplegia, ataxia. The mnemonic is GOA, G-O-A. Goa is a very famous tourist spot in India, especially for those who are watching outside India or those who have not been to Goa. It's a lovely place, beautiful beaches, vagara, vagara. Go for O and ataxia is the, Goa is the classical mnemonic to be remembered for Wernicke encephalopathy. So this is due to deficiency of vitamin B1, thiamine deficiency. And that can lead to, in the long term, it can lead to severe memory impairment with or without dysfunction or intellectual abilities. The whole spectrum of disease as of now, time shortage, vitamin B1 deficiency. But again, I have a question for you. WhatsApp me. By now you already have my number with you. Well, when there is vitamin B1 deficiency in a patient, it can lead to some acid-based disturbance. What problem can occur with vitamin B deficiency? Write down the answer in your, and I'll appreciate you can WhatsApp me this answer on my number. I'm writing this because many people join late. What acid-based problem it can lead to? Quickly, you get 20 seconds to think and reply. WhatsApp me what problem can happen. Vitamin B1 deficiency. The answer is it can lead to lactic acidosis. Done it. Localization of lesion in spinal cord are all except. There are 4 options. You get 30 seconds to think and answer. Write down the answer in your copy A, B, C, D. Look, spinal cord lesion is there. All can be seen except. Well, by now you must have done the answer. Answer is crossed hemiplegia. But my question is, what is crossed hemiplegia? This you can write down in your copy. Don't WhatsApp me. Write down the answer in your copy. What is crossed hemiplegia? Quickly, you get 20 seconds to think and answer. This is a rank 1 question. Most of students are not aware that 3-4 questions based on this point only. Well, the right answer is cranial nerve involvement of one side and the hemiplegia of the other side is called as crossed hemiplegia. And this is definition. But what is more commonly asked is this: what are the causes of crossed hemiplegia? What are the syndromes where we have this problem? It is medial medullary syndrome. We are all well aware. This is seen in the lesion in the medulla. Artery involved is vertebral artery. In vertebral artery, ipsilateral 12th nerve palsy and contralateral hemiplegia will be there, site will be medulla. Then we have Miller-Guebler syndrome. Artery involved is ICA. ICA stands for anterior inferior cerebellar artery. 6th and 7th, and the site of lesion is pons. Then Weber syndrome, third nerve is involved in Weber syndrome. Artery involved is posterior cerebral artery. Posterior cerebral artery, anterior inferior cerebellar artery, and in this vertebral artery, lesion is at midbrain. They all lead to ipsilateral nerve palsy, cranial nerve palsy, and contralateral hemiplegia, so-called crossed hemiplegia. Now, important points. At least you should know one thing, that in lateral medullary syndrome, important negative point to remember, lateral medullary syndrome, there is no hemiplegia, and this occurs due to pica. Pica is posterior inferior cerebellar artery. It was anterior inferior cerebellar pica. Pica is a branch of vertebral artery. Okay, so lateral medullary syndrome, which can be caused by either obstruction to pica, or pica is a branch of vertebral artery, or from directly vertebral artery sometime. Okay, and this is here, crossed hemiplegia is not a feature, because in this hemiplegia is not a feature. But just to add on to you, in lateral medullary syndrome, Horner syndrome is a very important feature. Horner. So in a stroke patient, if you are getting Horner, then 99% you are dealing with lateral medullary syndrome. Lateral medullary syndrome is one of the most important question in all the exams throughout the world. So since it's so important, so let me add on to what else we all get in lateral medullary syndrome. You get ipsilateral cerebellar features. Ipsilateral 10th nerve palsy, 8th nerve palsy, 5th nerve palsy, then Horner syndrome. But contralateral loss of pain, touch, and temperature. You can write down full form, pain, touch, and temperature is contralateral. This is due to involvement of spinal lemniscus. Spinal lemniscus is nothing but the continuation of contralateral spinothalamic tract, but in the brain they are known as spinal lemniscus. To make a box of this line also, and you'll be, this question comes in all the exam, okay, every exam throughout the world. So you might get one question from this also. So I'm leaking the paper to you, but in a very honest way. Chaliye ji. With this we move further. Just a minute, system has hanged. Technology also have their own problem. Just a minute. Oh, thank God. Weber syndrome include all except. Again, a very important question. The answer is superior cerebral peduncle is involved, is not involved. This is the wrong answer. The Weber syndrome, as I mentioned in the previous slide, is PCA, ipsilateral third nerve palsy, and contralateral hemiplegia is Weber syndrome. Again, a very commonly asked question. In fact, it's a very important long question in those who are going for MD medicine. And MD medicine usually is a long case, is a neurology case, and this is one of the most favorite long cases to be kept in exam, in practical exam. Now, this is again rank 1 question, not a criteria of major criteria of Neuromyelitis Optica. Write down the answer in your copy. I give you 20 seconds to think an answer. Well, the right answer is focal epilepsy. Now let me tell you what do you mean by Neuromyelitis Optica, so-called Davis disease. It's an aggressive inflammatory demyelinating disorder. Point to be noted. Demyelination. Just like other demyelinating diseases are multiple sclerosis, GBS, Guillain-Barré syndrome. Some people pronounce Guillain-Barré syndrome. Some people pronounce Guillain-Barré syndrome. Well, different way of pronunciations are there. But however, MS and GBS are again demyelinating disorders. They are characterized by recurrent attack of optic neuritis and myelitis. Point to be noted, these can occur in multiple sclerosis also, but it's a unique variety where the other two highlights. Let me talk more about this. The core clinical feature, as I told you, optic neuritis and acute myelitis. This is the core. But what else? Patient can also have a area prostremia syndrome. What is this? Episodes of otherwise unexplained hiccup, nausea, vomiting. Hiccup is a big problem. Like this, hiccup. This is the main problem. Vomiting also, nausea, but hiccup is the main problem. And of course, hiccup unexplained, get all the investigation, nothing, we are getting it. At some time, patient can have acute brainstem syndrome, feature of brainstem. I mentioned few in the previous slides. And there can be narcolepsy. Narcolepsy is irresistible tendency to sleep. Okay? Irresistible. Patient want to sleep, he has to sleep. Maybe acute diencephalonic syndrome. Now, let me give you are tired by now, let me make you fresh also. Study should be fun, it should not be a punishment. Can anybody give me example where normal physiological narcolepsy occurs? Narcolepsy occurs where? Normal to normal person. And I'm sure this must have happened with you also. I tell you one story. Especially summer months in city like Delhi. It is a post-lunch session in your medical college. Summer month, post-lunch session, and the class is of biochemistry. And you have already taken lassi or chach in lunch, then this is the narcolepsy. Everybody must have experienced. Yes or no? Those who have experienced normally must WhatsApp me, sir, I experienced narcolepsy in the class, maybe biochemistry class. So, dear friend, summer month, lecture theatre, post-lunch session, and you have a sound sleep. This is narcolepsy. Well, we come back. Study should be fun, as I always say. So, what is the problem in Davis disease? Aquaporin 4 on astrocyte cell membrane is the site of disease. This is an important question. Rank 1 question is this. Treatment, we have got sterilizumab, the new drug. It's a IgG2 monoclonal antibody for the treatment of NMSOD in who have got aquaporin 4 antibody positive. So just remember this name and the mechanism of action. Okay, this again rank 1 question. Tongue fasciculation are seen in which the following condition? I give you 20 seconds to think an answer. A, B, C, D. Mark the answer in your copy. Well, the right answer is spinal muscle atrophy. Well, it's a part of MND, motor neuron disease. So let me talk a little bit more about MND. In MND, the spine can be involved or brain can be involved. Well, if there is progressive spinal muscle atrophy, we call as PMA, is a type of lower motor neuron in the spinal cord. Primary lateral sclerosis, PLS, is a upper motor neuron feature. And if both are there, then we call as amyotropic lateral sclerosis. This is the most widely presentation. And at times they will not write MND, they will simply write amyotrophic lateral sclerosis, both upper and lower motor neuron feature will be there. But sometimes there can be involvement of the bulb also. We call as progressive bulbar palsy when element features are there, and pseudobulbar palsy when upper motor neuron features are there in the cranial nerve. Okay, most of people are not aware of this point. Let me talk more about what are these two entities, not clear to all of you. Well, let us say this is the left side, this is the right side, this is the third nerve in the midbrain. Definitely it is coming like this, third nerve. The lesion occur in this place or in this nerve. This will be lower motor neuron palsy. This we saw in Weber syndrome, ipsilateral third nerve palsy, contra hemiplegia. So nerve is okay, fine, but most of students are not aware the way each anterior horn cell is controlled by a contralateral motor cortex. Similarly, motor cortex, on the right side, it will control the cranial nerve of the other side. That means each cranial nerve nucleus has a control from the contralateral motor cortex. The lesion occur at this side will be ipsilateral lower motor neuron lesion, so called okay, and if the lesion occur here, we call as upper motor neuron lesion, but it will be contralateral. Well, we also, this is regarding, we came to know for the first time that even in the cranial nerve also upper and lower motor neuron palsy does occur. Now we have 4, 9, 10, 11, 12, which usually arise from the brain stem. If any one of the lesion occurs in this, if it is a lower motor neuron palsy, we call it bulbar palsy, and if it is upper motor neuron palsy of any one of these four nerves in more particular, we call it pseudobulbar palsy. But one thing I am repeating again, every cranial nerve has, as the nucleus has got control from the contralateral motor cortex. Well, so they are the upper motor neuron lesions of the lower 4 cranial nerves. We treat by Riluzole or edaveron. But now a word is, I use a pseudobulbar palsy. In this we have a pseudobulbar effect. I want you to again write down the answer. What do you mean by pseudobulbar effect? And send me the answer immediately. You get 60 seconds to think an answer. What is pseudobulbar effect? This is rank 1 question. What is pseudobulbar effect? WhatsApp me. Okay, I hope by now you must have done it. This is so-called inappropriate and involuntary laughing, crying. It affects social relation. Inappropriate behavior, to be more precise, you can write like this also. Inappropriate behavior. Inappropriate behavior. What do you mean by this? Well, a person has gone to a funeral, cremation going on, everybody is sad, weeping, crying, and this gentleman start laughing, ha 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 ha, cracking jokes, start dancing. It's not an appropriate behavior in the cremation ground. Suppose this patient goes to a marriage party where everybody dancing, laughing, okay, enjoying, and this gentleman crying at one corner or in the middle of the party start crying. So this is abnormal behavior, not appropriate to the occasion. So we call it pseudobulbar effect. But the problem is it affects social relations. Definitely. You have gone to a party of a host who has invited you, doing a beautiful party, everybody coming, and this gentleman crying. So definitely host will be very uncomfortable why my guest is crying. So what the books write, if the patient has a problem like this, you must inform the host that this problem is there. It's not a deliberate, it's involuntary. It's not a deliberate, involuntary type of behavior is there. That point is again very essential to tell the host also. Anyway, as far as we are concerned, for exam point of view, it's an inappropriate behavior. In a nutshell that I can say, pseudobulbar effect. Well, it's a question from biochemistry, latest exam question. What's the best method to assess HbA1c? Okay, it has come twice. That's why I thought I must include. Its answer is A, ion chromatography assesses HbA1c the best. Well, it's a question of interest or diabetes. We also know that HbA1c tell you sugar value for the last 3 months, everybody knows. Okay. We also know that now HbA1c more than 6.5% is also a diagnostic criteria for diabetes. That also we know. And one more thing, again a biochemistry question, that by HbA1c we estimate average, estimated average glucose which correlates very well to the HbA1c. There are 3 things that we talk about. So it tells you sugar value for last 3 months. In fact, it was the first thing that we were taught about HbA1c. Then later on we came to know about the new thing added on was more than 6.5 is the diagnostic criteria, and finally estimated average glucose. But anyway, and we just know is tell you value for the last 3 months. Now my question is, in which diabetic condition HbA1c is not used? My number is written. You can WhatsApp me right now. In patient has diabetes and we want to know the long-term prognosis, but we will not use HbA1c. What are those conditions? WhatsApp me. You get 60 seconds to think and answer. Diabetic patient where we don't want to use HbA1c for the long-term prognosis. Quickly WhatsApp me. Diabetic condition where we don't want to use HbA1c for the to know about the long-term prognosis. Name the conditions. WhatsApp me. Well, pregnancy and any hemolytic anemia or hemoglobinopathies. Here we will not use. I'll especially talk about pregnancy, but they are not very common thing. Pregnancy, diabetes. Why we do not want to use? Just now we learned that HbA1c tell you sugar value for the last 3 months. Now suppose you are doing diabetic practice, a pregnant lady come with diabetes. And we all know, I don't need to tell you that a long-term complication of diabetes diabetes on pregnancy, on mother or fetus is a long topic taught to you by your obstetrician. It's a long topic. But as of now, diabetic pregnant lady come to us as a physician. So we are concerned with strict diabetic control, because this diabetes is going to affect fetus also in long term. So we need a strict control. So we cannot rely on 3 months figure of diabetes. So we use fructosamine. We tell you sugar control of the last 2 to 3 weeks. In contrast to HbA1c, we tell you sugar value for last 2 to 3 months. So in this scenario, in particular in pregnancy, we like to use fructosamine to get the absolute correct value, so that we are very vigilant. Otherwise, it may create problem for the mother and the fetus. Question 15. We are getting a 40-year-old male protrusion of chin, excessive sweating, impaired glucose tolerance, enlargement of hand and feet. Oh, enlarged hand, feet and chin. Okay, I think it's a case, apparently it looked to be a case of acromegaly. Okay, what is it? Aha, growth hormone receptor antagonist. Good. So that means the question wala also agrees that we are dealing with acromegaly. But the question is, he says, which is the growth hormone receptor antagonist we like to use? Options are there. Write down the answer in your copy, A, B, C, D quickly. You get 20 seconds to think. Quickly. I'm sure by now you must have done it. Well, the right answer is B. How many of you done B? Raise the hand quickly. Well, B is the most common wrong answer. Answer is A. Why A? Why not B? Let's learn the basic concept. Pegvisomant is a growth hormone receptor antagonist used in resistant acromegaly. So the question was growth hormone receptor antagonist, pegvisomant, is the second line drug treatment for acromegaly, not the first line. What is the first line and why? I'm going to discuss in the next slide. So let's learn about basic concept about growth hormone physiology. The growth hormone physiology, from the hypothalamus, we have a growth hormone releasing factor. We also have a growth hormone releasing inhibitory factor. Growth hormone releasing factor and inhibitory factor, and this inhibitory factor is also known as somatostatin. Octreotide is a somatostatin analog. So you can say octreotide is nothing but a type of somatostatin. Now we know this is the one which is going to stimulate pituitary hormone to secrete growth hormone. This is an inhibitory hormone. If I have to give you a day-to-day example, that releasing factor is a type of accelerator. We all drive some vehicle, motor car, bike, or scooty. So every vehicle has a accelerator. This is the accelerator, and brake also, that is needed to stop the vehicle. So they too control growth hormone secretion, so-called somatotropin. Now this comes to the receptor organ. In this we have a receptor, and the name of the receptor is IGF. Receptor is there, and this receptor is there, receptor. This will release IGF-1. So it is the IGF-1 which is going to do all the action at the peripheral tissue. The name, so receptor will be there for IGF-1, which will release IGF-1 and cause all the growth, whatever it is to be. But now this is known as somatomedin. And I assure you this is very confusing. So let me make it very simple. The duty of a teacher is to make the subject very simple. So let me make subject very simple. Somatostatin, what is this? It reduces statin. Statin. Yeah, it reduces cholesterol. Oh, it is reducing growth hormone. Yaad ho gaya. Yaad ho gaya. This is somatomedin, IGF-1. Growth hormone doesn't do the work himself. He has a via media. The name of media is somatomedin. And finally, it is itself is tropin. Now it's become easier for you to remember the name. Somatostatin, somatotropin and somatomedin. So suppose the patient of acromegaly comes, first line treatment will be octreotide. First line treatment. It is a somatostatin analog. It will reduce the growth hormone level at the central level. But you are giving this drug, patient not getting benefit. Then we like to give for pegvisomant, which is a IGF receptor antagonist. It will be acting at this level. It will block the receptor. The drug will come, it will not act. So it is a growth hormone receptor blocking drug. So I hope you are clear about it. So So we learned about octreotide, we learned about pegosamine, but now let me think more. Octreotide is one of the most widely asked questions in the exam. The question will come to you also. I'm leaking the paper to you, but in a very honest way. Okay, this line I'm speaking to make you emphasize that you don't have to forget these. Okay, something we have to tell you again and again, the importance of something. Well, in a very lighter way, I say that in the classes, when I take live class, I say if you forget, octreotide is a punishable offense. Why? If those of you who have traveled in Delhi Metro, they announce in Delhi Metro eating and drinking is a punishable offense. In Hindi say Delhi Metro में खाना पीना एक दंडनीय अपराध है. In a lighter way, I also say if you forget octreotide, ये दंडनीय अपराध है. Don't forget such an important point. So we use not only for acromegaly, but we use for secretory diarrhea also. We use for varicose bleeding also because it has the property of vasoconstriction. It causes splanchnic vasoconstriction, so it reduces the bleeding from varices. It is also used in neuroendocrine tumors. So you can see, in fact, there are large number of more uses are also there. Again, time constraint is there, so that's why I touched upon only few of them. But there are many more uses. That's why I say, don't forget octreotide. Cabergoline is a dopamine agonist, second-line drug for management of acromegaly because growth hormone is co-secreted with prolactin. Or you can say prolactin is co-secreted with growth hormone, both come together. That's why in case of acromegaly, galactorrhea is there. So we want to take care of that, we have to give cabergoline. It is done mainly to take care of dopamine. Oligocygepant is a selective calcitonin gene-related peptide antagonist, and this we use for acute migraine treatment. We use for prophylaxis also, but mainly for acute migraine. This is a new drug. This is a VVIP drug. VVIP drug is the one which are bound to get this question on newer drugs. Well, a question on acid-base disturbance. In one question in all the exam throughout the world will be 1 or 2, 3 questions from acid-base, and electrolyte also 1, 2 questions. A patient presented with emergency, pH 7.21, CO2 is 80, bicarb 35. What is the most likely disturbance? Again, you get 20 seconds to think and answer quickly. Write down the answer A, B, C, D. Quickly. Well, if you look into this, quite a few must have marked this. But this is the most common wrong answer. Answer is A. Why is it so? If you look into pH 7.21, it's an acid. This is acid, acidosis. CO2 is raised. Normal pH is 7.36 to 7.44. CO2 is raised. Normal CO2 is 40. Only 40. 40 to 45, yes, artery and 45 vein. But for ABG, we take arterial sample, 40 is the answer. So anything above is raised CO2 like this. So this is a case of respiratory acidosis. Why somebody has marked, he has not noticed the 7.21. Normal bicarb is 24 to 22 to 28. They saw and they went for metabolic alkalosis. Don't commit this mistake. Read the question very carefully. Otherwise, you are bound to commit mistakes. Well, a quick recap is a beautiful slide. Raised CO2 is respiratory acidosis, and decreased CO2 is respiratory alkalosis. Increased bicarb, metabolic alkalosis. Decreased bicarb is metabolic acidosis. This is the base of the entire acid-base disturbance. A diabetic person recovered from COVID to severe hemifacial pain, loose. Next step in the management is what? Write down the answer in your copy. A, B, C, D. Well, the right answer is MRI. This is a case of mucormycosis in a common diagnosis in post-COVID. Immune compromise, especially diabetes. In fact, has more come into notice after the COVID, but it was there very well common. It's a complication of diabetes, uncontrolled chronic diabetes. But it has come to notice, very much notice after the COVID. In diabetic patient in particular, it affects nose, sinus, eyes and brains. Right? So diabetic patient, the key word in this particular slide. Now keyword is a fungal infection. It's fatal. If you do not treat, it's fatal, and the drug of choice is amphotericin B. Now one question about amphotericin is universal. Which electrolyte imbalance occurs when we treat a case, any case with amphotericin B? Quickly write down the answer and WhatsApp me. In my WhatsApp number given to you, which electrolyte imbalance occur when you are treating any case of amphotericin B. You get 60 seconds to think and answer. It's beautiful, universal question is there. I have seen this question in MRCP, MLE, PLAB also, Indian PG also. This is universal question, amphotericin B. One more thing I'll tell you, in all the exam, they ask one or two questions of special side effect of antimicrobial or anti-cancer drug. However, I am sure you have done it by now. The right answer is, usual question is hypokalemia. This is known to 30%, but 95% people are not aware it can lead to hypomagnesemia also. Make a box of this line. The electrolyte imbalance which can be caused by amphotericin B is hypokalemia, the most widely asked question, and hypomagnesemia also. Well, we come back to our question of rhinocerebral mucormycosis. MRI with gadolinium contrast is the investigation choice in rhinocerebral. Why can't we use nasal swab? It can simply detect the mucor, fungus, but it cannot tell you the extent of the disease, which we are really interested. In MRI, we can get a report in just 1 hour time, and swab and etc. processing also can be done very fast. But this is definitely much better investigation. Somebody may argue with me, why not this? One thing you got to know, when you go and read the instruction in the exam, examiner never say choose the right answer, he say choose the most appropriate answer. So out of these options, this is the most appropriate answer, better than this one. It has got no role to do in this, particularly in this case, and serum ferritin has got no role in this particular condition. Hence, MRI is much better investigation, because any good diabetologist can pick up the problem. Let me show you the beautiful picture also. This is the way patient come to us. Environment of the face, nose, this is extensive environment of eyes also. The clinical diagnosis, and it's a very fatal condition. We don't have to wait. We can start amphotericin therapy as well as we can go for MRI also, but don't delay it. Well, it's a beautiful question. We are getting ECG shows which electrolyte imbalance. This is the universal question. Again, I give you 30 seconds to think and answer. 30 seconds to think and answer. Quickly write down. Well, the right answer is hypokalemia. ECG finding of hypokalemia and hyperkalemia is very, very important. Universal, in fact, from electrolyte, sodium, potassium, 2 or 3 questions always come. So let's talk about what are ECG finding in hypokalemia. ECG finding. This is a normal finding. T wave. When hypokalemia start, I request you not to write till I say stop writing. When hypokalemia start, this T becomes short and prominent U wave appears. Now you draw it. Draw it now. This T has become smaller and a prominent U wave has appeared. Done it? Now again stop writing. In still more hypokalemia occurs. This is a P wave, P wave. Look into this. This is PR interval. Yeah. First you see the slide. This P wave has become tall. Look into this P wave. P wave has become tall. PR interval has increased. T has disappeared or become smaller or ST segment depression. Prominent U wave and there is a prolonged QT interval. Now you draw it. Draw it carefully. Make sure that you are drawing a tall P wave. Make sure that you are drawing a prolonged PR interval. T disappear, prolonged QT and U wave are the finding. Point to notice U wave can be a normal finding, but somehow in the exam they usually use this term with hypokalemia. In fact, in the exam question you are getting the U wave. At least you can think about hypokalemia also. So I hope by now you have drawn it. So we have one finding is tall P wave, prolonged PR interval, T disappear, U appears and prolonged QT interval. Out of all these 5, you forget 4, I don't mind. But if you forget this QT interval, ये दंडनीय अपराध है, punishable offense, don't forget. Extra point, in fact, hypokalemia is the most common cause of prolonged QT interval in actual practice. And prolonged QT interval itself can progress to other arrhythmias, so-called torsades. Well, I have one more question for you. Here we have got tall P wave. What is the name of this tall P wave? Now you WhatsApp me this question to me. I hope you have drawn this picture. Again, I leave it for a few seconds more for those who have not drawn the picture. And just to remind you, prolonged QT is the most important question. इसको भूलना दंडनीय अपराध है. Repeating second time. The idea of repeating is make you emphasize the importance so you don't forget it. Now the question is, what is the pseudo P pulmonale? What do you mean by, in fact, you can WhatsApp me. You can WhatsApp me, what do you mean by pseudo P pulmonale? Quickly WhatsApp me in this question. Number is given to you, which already have written, but why I write? Many people join late, so they should have the number. Well, the answer is, normally we say P pulmonale. It indicates right atrial enlargement. This is a normal P wave. But if you get a P wave like this, tall P wave we call as P pulmonale. P pulmonale. This we get in right atrial enlargement. But here we are getting a tall P wave, but there is no right atrial enlargement. So we use the term as pseudo P pulmonale. Just to add on to your knowledge, if you are getting a wide P wave like this, height normal wide P wave, we call as P mitral. This you get in left atrial enlargement. The left atrial enlargement you get P mitral wide P wave, and tall P wave is right atrial enlargement is and P pulmonale. This is called P pulmonale. But in case of hypokalemia, repeating second time, this is not right atrial enlargement, so we call it pseudo P pulmonale, tall P wave. Question 19, which is not a correct statement about Brown-Sequard syndrome. You get 20 seconds to think an answer. It is a hemisection of the spinal cord not complete, and it is classically backstab. Somebody has given the backstab, and in that case half of the spinal cord is cut. We call as Brown-Sequard syndrome. In this, there is ipsilateral loss of position vibration sense. P for position, V for vibration. Ipsilateral upper motor neuron lesion. Contralateral loss of pain, touch and temperature. This is Brown-Sequard syndrome. It's a hemisection. In fact, whenever you get a backstab, किसी चक्कू मारा है back में, somebody has picked the knife, it will cut one half of the spinal cord. Okay? If complete section of the spinal cord, that will lead to complete paraplegia and all sensation will also be lost. But this is what typical backstab Brown-Sequard syndrome. So ipsilateral loss of position vibration and upper motor neuron, contralateral loss of pain, touch and temperature is Brown-Sequard syndrome. It's a very important, frequently asked question is this. Now the last question of the day. A 45-year-old present with history of bilateral lower limb weakness, upper limb also involved. Then we are getting sensory loss and are absent. There is no autonomic feature and there are no sensory loss. Most likely diagnosis. Well, this question partially we discussed earlier is the amyotrophic lateral sclerosis, which is a type of motor neuron disease, if you remember. Okay, in this we have feature of both upper motor neuron and lower motor neuron features. Amyotrophic lateral sclerosis is there. And remember, as I told you, spinal muscle atrophy, this is the lower motor neuron features. This point I discussed in earlier on the question. Only LMN and amyotrophic lateral sclerosis are both LMN and UMN. Now, I always say study should be fun. This, anybody recalls, there was a very famous Hindi movie, and I'm sure all of you must have seen this. The term came. All of you must have seen the movie Munna Bhai MBBS. Yes, you remember? In Munna Bhai MBBS, the scene comes that Munna Bhai, Sanjay Dutt has gone to write the exam. And the professor sitting at home, now he is saying, write down spinal muscle atrophy. Professor speaks and Sanjay Dutt writes. So next time when you see this movie, when the scene will come, आपको मेरी याद तो आएगी. Definitely you will think about me. Dr. Bhatia mentioned about this point that spinal muscle atrophy is a type of lower motor neuron type of muscle atrophy. It just study should be fun, is my way. So I was talking to you, human feature are spasticity, increased reflexes, DTR, and plantar upgoing. And element, fasciculation, asymmetric distal weakness, and atrophy are the feature of lower motor neuron. This is a universal truth. Treatment of MND is xyluzole and new drug is edaveron. It's a scavenger of oxygen radicals. So friends, this is all for today, and I'm sure you will be having some queries to ask me. Time is limited, so I have given you my number also, which is already with you, but again for those who join late, okay, and you can very well note down my email ID also. This WhatsApp number at the moment number is closed, but soon after class I'll switch it on. I'll get all the messages. How was the session? Feel free to share your testimonial. I'll say them as a return gift from you, okay, and you can send at this number only, I'm sure. Now, well, there are few videos I can share with you, and you can note down the number of my staff, Madam Aruna, okay, send hello to her. Don't forget to write your name, college. Even when you are writing testimonial also, don't forget to write your name, college, and which year you are. And she'll be sending you lots of free videos, and from those videos you are bound to get some questions. I hope you have written this, or you can take a click of this to get some free videos. Well, this is the Medicine Simplified Mini Harrison question bank, but at the moment you are writing your exam, next month you don't have to read this now, but definitely you can pass on the message to your juniors that they can. It's the ultimate book of Harrison, Mini Harrison. Harrison is the ultimate book of medicine, but it's too vast. Reading one page of Harrison need half an hour. To understand you need 2 hours, but you need only 2 minutes to forget what is given in that page. So not advisable to read Harrison at your level. It's a mini Harrison, what is written what you need. This is what is more important, that somebody tells you what you need, not all the details. Medicine sends the question bank. Just to inform you, we also have MRCP courses and USMLE courses. Again, MRCP is a world recognized postgraduate degree of UK. You can online recorded lectures, and if you want, you can very well contact my staff, Aruna Madam. She'll be talk more about this also. But it's an ultimate degree, UK degree, without any competition. You can once you pass MRCP, it is equivalent to MD medicine. Go to UK, earn a salary of 80 to 90 lakhs per annum, and you can do super specialty after 3 years without any competition exam. But this is all just for information. We should inform you. Well, before I close, everybody needs somebody. Nobody can live alone. We need somebody to whom we can talk, we can share. We need the best friend. The best friend is the one who understands you, give you right advice. So today my friendship started with you. I'm the best of the best friend for you. Any query any one of you have, you can feel free to talk to me, and I'll be guiding you at the best of my capacity in the most confidential way. Because in the friendship we need confidentiality and trust. तो दोस्तों इस बात पे एक शेर अर्ज है. इरशाद बोलो इरशाद. या ये दोस्ती एक चिराग है, इसको जलाए रखना. ये दोस्ती एक खुशबू है, इसको महकाए रखना. ये दोस्ती एक चिराग है, इसको जलाए रखना. ये दोस्ती एक खुशबू है, इसको महकाए रखना. हम रहे हमेशा आपके दिल में. DBMCI रहे हमेशा आपके दिल में. इतनी सी जगह बनाए रखना. Thank you very much, dear all friends. Wish you all the best. May Lord Ganpati Ji should always bless you so that you remain happy, successful throughout your life. Success is not a final. Failure is not the fatal. It's the courage to continue that counts. the very famous quotation for you, for all of us. But I go beyond that. I say, let Lord Ganpati, you should bless you with always with success. We go beyond this line also. Okay, thank you very much. I hope you all enjoyed, learned, entertained me. Don't forget to send a testimonial, and I'll save them as a souvenir from you, as a return gift from you forever. Thank you very much and wish you all the best. Bye-bye.